So, hello everybody. First of all, I wish you a very happy new year, hoping that we can get off of all that mask and stuff we put on and around us during this new year. Please, can you close your microphones because I hear a microphone? Before we begin with this webinar, I want to present you the speakers again. The first speaker will be Professor Subramanian from Leeds, who will speak about the use of AirSeal in robotic surgery. The second speaker will be Thomas Blanc from Paris Necker Hospital. We will speak also about robot, but a little bit more concentrated on COVID problems. And finally, Stephen Rosenberg from Denver will speak about the use of AirSeal in very special operation vertebrate body theater. But before we really begin, I wanted to share with you a short 3 slides about the literature about AirSeal, and you will see that there is quite a lot of literature still published about the use of the AirSeal in different circumstances, of course mostly in adults. So when you look to the literature, you can see that there are a lot of papers published since several years about the fact that the use of the AirSeal gives a more steady volume during the operation. And there were publications concentrating on this steady volume in bariatric surgery, robotic surgery, nephrectomies and heminephrectomies, and also in rectal surgery. And you see that there are quite high quality papers published, because one of these papers was prospective and 2 others are randomized. All those papers show that AirSeal gives a more steady volume during the operation. There is also a paper published, and it's also a randomized study about the fact that when you do the operation with this tool, you save time, and this is also important, of course. Other papers concentrated on the view, because there is a smoke extraction system inside. So the fact also that you have a more steady space gives you a finally better view all along of the operation. And also you have lower high pressure episodes. And this seems particularly interesting in pelvic surgery, where you have in standard with standard systems to increase a lot sometimes the pressure to see better. What is interesting in children is that it seems that you have better pain control and also a decrease of postoperative morbidity. And there is a randomized study, very interesting, about cholecystectomies in sickle cell disease. And they show that with the use of this AirSeal system, you have better pain control than with the standard tool. And finally, there are, of course, it seems, anesthesiologic advantages, because I know there are some anesthetists participating in this webinar. Of course, there is a decrease of dioxide absorption, and it's also, you see, a randomized study. And another randomized study where you have here the paper show better respiratory mechanics. You have to read this paper because there are a lot of things that were studied. The inspiration plateau pressure, the minute volume, the CO2 elimination rate, the end-tidal CO2, static compliance, and all those items were all better during anesthesia. And this is perhaps a very interesting study, also randomized. It's from a Belgian team that is very busy in morbid obesity surgery, very well-known team. And they show that with the use of the AirSeal system, you can finally do an opioid and anti-inflammatory free anesthesia. And this is, of course, of main interest if you want to put those patients up very soon and decrease the morbidity due to the fact that they stay in the bed for a while. And there are also experimental studies done in Strasbourg by the Maresco group showing the same, that inflammation is much less with this AirSeal system. So that was just an introduction to show you what this tool can bring to surgeons, and in particularly what they can probably bring to pediatric surgeons too. And to prove you that, we asked Dr. Ramat Subramanian from Leeds to give first his experience about the use of AirSeal in robotic surgery in pediatric urology. Ramat, it's up to you.
Thank you, Henri, and thank you, everybody. There's a pre-recorded presentation which can start shortly, and I just want to say that I'm actually talking about how I accidentally came across AirSeal whilst I was trying to restore robotic surgery in Leeds during the pandemic and the concerns that was raised at that time. And then the rest is will be a story which basically will be clear when you look at the presentation. So Paul, please play the presentation for me, please. Thank you. Thank you very much to the organizing committee. Thank you to CONMED. And thanks again for the opportunity to participate in this webinar. And my topic today is impact of AirSeal in pediatric robotic surgery during the COVID pandemic. It's a real honor to share the platform of this webinar with colleagues and who are obviously experts in their own right
we don't hear
in minimally invasive surgery within children. My story in terms of getting involved with the AirSeal begins early in the pandemic, which was declared in March 2020. And this is a briefing from the European Robotic Urological Section, which is a section under the EAU. And essentially, as we all know, it's been a catastrophic pandemic with significant impact on the healthcare system worldwide. And so obviously medical practice had to adapt and change really quickly. And the aim was, of course, maximum protection of healthcare professionals. But at this point of time, I want to say it's just not healthcare professionals. It's risk to a lot of people, including patients and the community at large. Italy is one of our colleagues in Italy. I mean, they really have suffered significantly in the initial part of the pandemic, but subsequently it spread everywhere. And we have not been spared its impact in the United Kingdom as well, where we are one of the countries with the significant mortality due to the COVID-19. What is significant is that in relation to the pandemic, it's not just the direct care of caring for those patients who are affected by COVID-19. It's the side effects is of those people who have not been diagnosed with COVID-19, or those who are asymptomatic with patients. They might act as a vector during laparoscopic or robotic procedures because there is a generation of aerosols which can contain these virus particles. And therefore it can be a risk, as I mentioned earlier, not just to surgeons, but also the staff, the healthcare professionals around the team and the patients alike. And it's important that we minimize these collateral damage from patients who are requiring care in the hospitals for non-COVID conditions. It's also recognized that there might be a delay in the non-emergent cases rather, and especially in the setting of urological surgery, and it might risk suboptimal outcomes, for example, in cancer or similar scenarios. In Leeds, we also felt the impact of minimal access procedures, and particularly in children where I work exclusively. And it's important to mention here that Leeds is a pioneer center in the United Kingdom for robotics in children. We have one of the largest experience with robotics, and I also play a proctorship role, and I've helped establish robotic training programs in UK and Europe. So there's a big responsibility when it comes to making sure the minimally accessed procedures, especially robotics, can continue to do so in a safe environment. And the issue is that in case of non-deferrable surgery, the importance is to minimize the surgical smoke during laparoscopic procedures. And it was decided that you should only use minimally accessed or robotic procedures only when it's absolutely essential. And it may be of particular importance that the intra-abdominal pressure, which is used to create the space for these procedures, is kept to a minimum. And in that regard is where the role of these AirSeal, which gives rise to these intelligent integrated flow systems, and these were recommended. So the use of these devices allows us to keep the intra-abdominal pressure as low as possible, ensuring a self-maintained constant pneumoperitoneum. And these systems need to be configured. They are specifically, what happens here is an ultra low penetrating air filter that meets guidelines to capture particles above 0.01 microns. And the virus size, in terms of the aerodynamic size, has been reported in the range of 0.06 to 0.1. Now, in consequence, the use of these devices therefore may have a role in reducing the diffusion of these virus particles during surgical procedures. So in addition to mitigating the aerosol generation risks during the pandemic, there are additional benefits, which includes maintaining the pneumoperitoneum at set pressures. And this is despite minor leaks or if you use suction during these procedures. And it allows the safe performance of these procedures under reduced pressures. Now, in my opinion, it also allows safe practice, especially when it comes to training surgeons. Because if there is a leak from a pneumoperitoneum, then that needs expertise to troubleshoot, and therefore there's a lot of distraction during a particular procedure. But what AirSeal does is to maintain these pressures, ensuring no loss of pneumoperitoneum, even if there is a small leak in and around the ports. And therefore, training surgeons become safer without any risk or further distractions during the procedure. Now, what's a direct impact for me in robotics in Leeds? Previously in our department, robotics was only performed in children over 12 months of age, or they must have been minimum 10 kilograms in weight. Because the AirSeal allows these procedures under reduced pressures, we've been able to reduce these pressures to up to 50% from 12, which was our practice previously, to now between 6 and 8. And the age limit in which these procedures are performed has also come down to about 6 months from a previous figure of 12, again, by approximately 50%. And it's fascinating to see that there is a publication, which I was not aware about, a while ago actually, from a Japanese team, which performed two-pay fundoplication using an AirSeal intelligent system in a 1.8 kilogram infant. That's amazing. That's incredible. And that just shows what is possible when you have technology at its best. There are plenty of studies that's available on on AirSeal systems. And what the message is, as you can see here, the reduced operating time leading to big reduction in costs. And you can see here that the minimally invasive procedures during AirSeal, when you have less pressures, causes less post-operative discomfort in terms of shoulder pain and corresponding to less analgesia use. Reduced length of stay, and again, another publication talking about reduced incidence of shoulder pain, reduced analgesic requirements, and so on and so forth. Again, another one demonstrating shoulder pain. And if we move on to the next slide here, again, further evidence suggesting about AirSeal reducing pressure by 15%. AirSeal was superior to conventional systems. Again, time of operation reduced. So on and so forth. There are further evidence to the fact that AirSeal around 6 to 8 millimeters significantly reduces shoulder pain, narcotic use, peak average pressures, and therefore the physiology is less affected when you have pneumoperitoneum. And you can see a number of articles along those lines. So there are significant benefits for AirSeal, and although literature is predominantly in adults, it will take a little bit of time, as always, it's a lag before evidence in pediatrics can come to light. So all that remains for me is to say that the 3 AirSeal units at our theaters have been funded by donations, which has allowed safe resumption of minimal access procedures in Leeds from mid-June 2020 after a 3-month gap. And our heartfelt thanks to the donors and efforts of our own hospital charity. That's the Leeds Hospital Charity. I just want to say thank you once again, and I apologize if there has been some repetition amongst all the speakers, but that's inevitable in such a topic, and I'm happy to take any questions. Thank you.
So thank you so much, Namas. Before we discuss this paper, and don't hesitate for people who are following us to go to the chat to ask for some questions. We will look to what Thomas Blanc has to say about from a French point of view after a UK point of view. And once we have given his topic, we will discuss the 2 papers together. Thomas, happy.
Henri?
Ram, you want to say something?
No, this was Steve.
Oh, sorry.
I just think the paper was brought up about the infant with 1.8 kilos. I think we need to be very careful at this point in time about encouraging or recommending the use of this technology in that small of a child. It is certainly outside the guidelines and the appropriate use of this at this time. I appreciate what they did, but I think I don't want people to go away thinking that they should use this device at this point in time in that small of an infant.
No, I agree with you, Steve. I agree with you entirely, actually. But that's the only paper that's done literature, and it will be wrong not to mention it. But I would be much more careful. You're absolute. At the moment, we've just brought our age down to 6 months, so slow and small steps. But 1.8 seemed a big jump for us. But nevertheless, it's published. So
yeah, but again, I would issue a strong disclaimer as opposed to look what you can do. I think we need to be a little bit more careful.
Okay, thank you. We will discuss further after Thomas Blanc has presented his topic. Thank you, Thomas.
So good evening, everybody. I am Thomas Blanc. I'm a pediatric urologist at Necker Hospital in Paris. It is my great honor and pleasure to speak about AirSeal as a new insufflation device in pediatric laparoscopy, and I have no disclosure. So in 2002, the European Association for Endoscopic Surgery provide clinical practice guidelines for the pneumoperitoneum for laparoscopic surgery. First, they recommend to apply the lowest possible pressure level, and then they recommend that at the end of the operation to remove all the residual gas. So what is the good choice for insufflation pressure? Low insufflation pressure is between 5 and 7 millimeters of mercury, and normal insufflation pressure is between 12 and 15 millimeters of mercury. And the panel recommended to use the lowest intra-abdominal pressure, allowing adequate exposure of the operative field rather than using a routine pressure. In 2014, a review was published comparing low pressure and standard pressure pneumoperitoneum for laparoscopic cholecystectomy. And the conclusion of this review was that low pressure pneumoperitoneum significantly decreased the postoperative pain with a shorter length of hospital stay. So this is an example of retroperitoneal approach in an 18-month-old boy with a posterior urethral valve and non-functional kidney. So here you have the peritoneum, you have the psoas muscle, and you have the ureter. And this is what happens when you do such approach and we use your suction. You see that your space is very limited and you cannot keep working due to the suction. So the AirSeal system is a class of valve-free insufflation system that enables a stable pneumoperitoneum with continuous smoke evacuation and carbon dioxide recirculation during laparoscopic surgery. It facilitates smoke evacuation and filtration with 0.01 micrometers ultra-low penetrating air filter. So this is the trocar, and you have 3 lumen. The inner lumen is for insufflation, the outer lumen is for constant monitoring of intra-abdominal pressure, and in between, it's for recirculation of CO2 and smoke evacuation. So how does it work? The system maintains stable pneumoperitoneum by recirculating filtered CO2 through tiny pressure nozzle within the proximal AirSeal cannula to create an AirSeal pressure barrier that is equal in force to the patient intra-abdominal pressure. An AirSeal mode allows the surgeon to operate with sustainable low pressure while maintaining the expected laparoscopic working space. So in this paper, you have a comparison of the average variation in pneumoperitoneum during the first 30 minutes of laparoscopic cases. With the AirSeal, you have a significantly less variability in pressure readings compared to standard insufflator. And there was significantly less time spent within the borderline range with pressure readings higher than 18 millimeters of mercury or lower than 12 millimeters of mercury. And you can see that with the AirSeal, 10 seconds after suction, you have a slight decrease in pressure at the start of leakage, but pressure was maintained higher than 13 millimeters of mercury. With the standard insufflator, you have a more substantial decrease in pressure to values of 7 to 13 millimeters of mercury, which was followed by overpressure recovery after the leakage was stopped. So at Necker Hospital in Paris, we have started the multidisciplinary pediatric robotic program 4 years ago. We have operated 368 children in urology, general surgery, oncology, ENT, thoracic surgery, transoral robotic surgery, and neonatal surgery. And when we started the program, we wanted to do complex cases in minimally invasive surgery, and we have started to use the AirSeal system. We have never used the system before the launch of the robotic program in Necker. I just want you to show two examples of very interesting case where the AirSeal has a very important added value. First case, this is an adrenal neuroblastoma in a 5-year-old boy, and the procedure was performed with a transperitoneal robotic-assisted laparoscopic surgery. So you can see the right adrenal with the neuroblastoma. Here you can see the vena cava, and thanks to the AirSeal mode, you can have an automatic and constant smoke evacuation, improving visualization while maintaining stable pneumoperitoneum. And this is very important because in this example, you work in a very, very small space. There is a risk of bleeding when you control the adrenal vein, and you don't want to take any risk. So you can see that with the AirSeal, when you have smoke, you just wait 2 seconds and the smoke is evacuated, but with a constant pneumoperitoneum. This case is also very interesting. This is an upper pole renal tumor in an 8-year-old boy. And in this case, the procedure was performed in a retroperitoneal prone approach. So you can see the landmark, and this is the posterior aspect of the kidney, and the tumor is at the upper pole. So in this case, you have a polar vessel at the upper pole that was controlled with hemlock clips. And then you have, this is the renal artery, and we decided to do a selective clamping of the renal artery. So I use a tourniquet and hemlock clips. And you can see the limitation of the partial nephrectomy. So thanks to the selective clamping, at the beginning there is no bleeding. You can see very well what you're doing. The smoke is evacuated very quickly. But in this case, when you have a bleeding, you don't want to choose between having a good view, suctioning, and to control the bleeding. So in this case, AirSeal is very important because if you have suction and you lose your pneumoperitoneum, you have to convert the case. So this is the final aspect after the tumor resection. And then this is the closing of the defect of the parenchyma with the sliding click rhinography technique. And you can see that you have a very good view thanks to the AirSeal system. So this is the specimen in the bag, and this is the final aspect of the kidney at the end of the procedure. So in these two procedures, the AirSeal is very interesting. What about the COVID? Ramnath already talked to you about the COVID. I will just show you the recommendation of the SAGES, the ERUS, and the AFU. So the SAGES is a Society of American Gastrointestinal and Endoscopic Surgeons. And as Ram told you, the ULPA filters can remove from a minimum of 99% of airborne particles with a minimum particle penetration size of 0.01 microns. And they recommend that all the pneumoperitoneum should be safely evacuated from the port attached to the filtration device before closure, before trocar removal, and before specimen extraction or conversion to open. And during desufflation, when you lower the pressure of the pneumoperitoneum, all escaping CO2 gas and smoke should be captured with an ultrafiltration system, and desufflation mode should be used on your insufflator if available. And with the AirSeal system, you can do exactly what is recommended by the SAGES. What about the ERUS? Of course, the ERUS recommend the lowest intra-abdominal pressure, and they also recommend the use of intelligent integrated flow system. Because the use of this device allows the surgeon to keep the intra-abdominal pressure as low as possible, ensuring a self-maintaining constant pneumoperitoneum. And what about the ULPA filters? With the AORN guidelines, the smoke evacuation and filtration mode allowed capturing of particles above 0.01 micrometers, and the SARS-CoV-2 aerodynamic size has been reported in the range of 0.06 to 0.01. So it means that the virus can be controlled with the filter. Same for the AFU, association, the French Association of Urology. So you can see that the SARS-CoV-2 aerodynamic size has been reported in the range of 0.06 to 0.01. And you can see that thanks to the AirSeal filtration mode, you can filtration with 0.01 micrometer with the alpha filter. This is one of the first paper about minimally invasive surgery at the beginning of the COVID with the experience in China and Italy. And this paper published in Annals of Surgery, there was a comments highlighting that the use of new insufflation systems such as AirSeal will offers continuous smoke evacuation through an ULPA filter, allows the capturing of particles higher than 0.01 micrometers. And you know that the virus is bigger than this. In France, we have studied the impact of the COVID on the robotic activity in the APHP hospital in Paris. In Paris, there are 13 university hospitals who have the robot at the APHP. And we have compared two periods. A normal period, the reference period, in September 2019, 7 weeks of surgery with 455 patients, adults and children, operated with the robot. And we have compared this reference period to the beginning of the COVID period in France, in March and in April, with 7 weeks. And first, you can see that there was a 60% decrease in activity because of the limited access to the operating room, but the oncological cases were kept for the robotic approach. And interestingly, you can see that the use of the AirSeal increased based on the recommendation of the societies. The use of AirSeal increased from 38% to 47% in the COVID period. So what are the drawbacks and limitations of the AirSeal? Of course, when you use the AirSeal, you have an excess CO2 consumption. There is a risk of hypothermia when you do this kind of complex and long procedure in small children. So you have to be very careful with hypothermia. I don't think that there is any risk of contamination of the intra-abdominal space with non-medical grade air during the section. It has been described, but I'm not sure about this. There is also a therapeutic risk of air embolism, but the major issue is the cost, because this system in France is 300 euros. So to conclude, patient safety is paramount in COVID period or not in COVID period, and the room for error is less in children. And I think that when you want to develop a robotic program, when you want to develop complex procedure in minimally invasive surgery, the AirSeal system is very interesting for complex procedure. Thank you very much.
Thank you so much, Thomas. I have a first question for you. Can you say something? You said something, but can you repeat it? Can you say something about how AirSeal facilitates the precision of your surgery? I think your two videos were very showed it very well, but you can perhaps repeat it.
Thank you very much, Henri. I think, of course, I've chosen two videos, but to show you that when you do complex cases in a tiny space, and you know that there will be a lot of smoke, you will need to do suction. If you do if you use a standard insufflator, when you do suction, you will use peritoneum, you will reduce your workspace, and it can be dangerous if you need to control bleeding in the example of the video. So I think that the AirSeal system is a very safe medical device when you do this kind of surgery. We don't use AirSeal for standard case, but when we do complex case, we use AirSeal because we are very convenient. And you know, when you do robotic surgery, you have to understand that the surgeon is at the console and the resident is at the bedside. So it's very important to control as much as possible what's at the bedside, and the AirSeal system helps the control of the procedure.
Hamnas?
Yeah, I think I would just echo what Thomas said, but just to say that if you mean a precision of surgery, we all know when we do minimally invasive work, it's that maintenance of the pneumoperitoneum is a single most important factor for us, especially when we go into small spaces, small areas in children. And if there can be a way to maintain it without any loss, either during any leak reports or suction, I think that allows precision surgery directly. And then you're able to focus then on the area where you want to work. And the other thing is, when there is diathermy use and there is smoke generated, again, AirSeal quickly revamps, recycles that air, and that also allows precision surgery. So there are all different factors which ultimately allow the precision of surgery.
Okay, and for the two, another question. Have you experienced reduced recovery time for your pediatric patients using the AirSeal compared to conventional insufflators? What about the reduced recovery time? Did you experience that?
I just need some clarification in terms of what do you mean by reduced recovery time? Are we talking about recovery from anesthesia? Or what are we talking about?
Probably the length of hospital stay, for example, or perhaps the length of staying in a recovery room. So can the child perhaps drink sooner? Did you experience something about that?
Well, generally, I don't think, to be honest, I don't think AirSeal has necessarily helped recovery in terms of feeding quickly or going home, because our robotic procedures automatically have already done that for us. So 99.9% of all my patients of robotic procedures, however complex they are, particularly because just in urology, so I don't do general surgery, but in urology, vast majority of my patients go home next day. And we have shown that even in complex procedures like Mitrophanoffs and some other auto augmentations and such procedures, they've all feed the same afternoon. So unfortunately, I cannot claim AirSeal has allowed, although I would like, but I don't think so. I think robotics generally has helped it automatically anyway.
Thomas, do you have an opinion about that, or did you study that?
I totally agree with Ram. It will be very difficult to compare patient operated without AirSeal and patient operated with AirSeal, because in pediatric surgery, the heterogeneity of procedure we perform will make very difficult comparison of a group of patients operated with AirSeal and with not AirSeal. But my impression is when your pneumoperitoneum is stable, when you can work with reduced pressure of pneumoperitoneum, it may reduce the tension on the abdomen, but it will be very difficult to prove.
So it was shown in a randomized study, I told you that, about cholecystectomies for sickle cell disease, where the pain control seemed to be much better with the use of the AirSeal system than with the conventional system. And we can guess that if the pain control was better, the length of the hospitalization was probably shorter due to the fact that this pain control was better. But of course, it's always difficult. My other question will be about, there is probably an interest in AirSeal concerning the CO2 absorption, certainly in little children and babies. So we know that the limitation, one of the limitations is the wideness of the trocar. 5-6 millimeter trocars is very big for babies. But Thomas, I heard that you did some robotic surgery even in little children. with the AirSeal, I guess. What can you say about that?
We have operated only 2 newborn babies because the Da Vinci system is not adapted at all to newborn babies. But we have operated for nephrectomy, for adrenalectomy, children at 4 kilograms and with a reduced pneumoperitoneal pressure. But I think that the AirSeal, because when you have, the smaller the child is, the more constant the pneumoperitoneum is a major advantage. And one other advantage with the AirSeal is the cleaning of the camera is really reduced. And I think that you sometimes you can lose time to remove your camera, to clean the camera. And we have seen that the number of camera cleaning in small children is really reduced when you use the AirSeal. So I think when you have to clean 10 or 15 times your camera, it takes 1 minute, 2 minutes. So when you reduce the number of camera cleaning to 1 or 2, you save time.
And so is the heaviness of the tubes that are needed to use the system not an issue? If
not really, because that sits on the I mean, I've not found it a big issue. I accept that it's a fairly much heavier tube than what we use, but it's not really caused any major issues from our practical point of view. There is one question on the panel I can see there about the abdominal pressure that was used prior to AirSeal and now using AirSeal. And I think I made it clear in the presentation that we'll be able to bring it down to about 50% in our practice. So somewhere around 10 to 12 to coming down to 6 to 8. I think that's a significant reduction in our pressures now. So that's a straightforward answer to that question.
Yes,
I'd just add, I think, if you're operating in infants, you should be using, one of the advantages of the AirSeal is that it's a valveless trocar. And so as we'll show in the thoracic bit, you can use different size instruments. But I think we need to be very careful right now about recommending people using AirSeal because of the large size of the trocars. The 5 millimeter trocar has an outside diameter of over 8, it's about an 8, which is much larger than if you operate on infants with 3 millimeter instruments and 3 millimeter trocars. So I just want to be a little bit careful about saying, this is great. The tubing is heavy. The trocar, I think they're working on all these things, and I think it's great, and the hope is that we'll get there. But, part of the reason we don't use robotics in small children is because the trocars are just too big, in my view. So I think I just want to be a little careful about going down this rabbit hole right now of using this in small infants. I agree. I think having a steady air pressure and all those things, all things which you can work out, not having cooling of the baby, having evacuation, all those things are important, but we're not quite there yet. And so I just want to be a little cautious, and the company is working very hard on addressing these things, and I believe they'll get there. But I just don't want people to walk out of here thinking that, it's routine. Use AirSeal on a 4 kilo baby, or use a robot on a 4 kilo baby for that matter. It's most of those operations, and we do the most advanced MIS procedures in the world in Denver, but we don't put 8 millimeter instruments or 12 millimeter instruments in a 4 kilo baby. Shouldn't be done, in my opinion. So I just want to add a little caution.
Yes, Steve, I accept your point completely, what you're trying to say. And I need to make it very clear that we also do a lot of these procedures extremely safely. And that's the reason why we had a limit of 10 kilograms minimum of doing robotics in these children. So now when we're trying to bring them down because of the pressures, it's in a very controlled fashion. So nobody's going to pick up a 4 kilogram and then put a robotics in. I think that's just extrapolating some of the information and getting a bit cavalier, I suppose, if people are really trying to do that. I think in tertiary hospital and teaching department, everything should be done in a controlled fashion. And that's what we are trying to advocate. But there's a definite advantage that you should be able to start reducing the weight, the procedures that is done
based upon age and weight in these children, but of course in a controlled fashion. I take your point completely that one needs to be careful about how we introduce these things without being too aggressive.
Okay, it's a matter of debate, you see. I use also, when I do robotic surgery, I guess I must be one of the last surgeons using the 5mm instruments, because I'm also always concerned about the 8mm trocar you have to use for most of the robotic surgery. But there are a lot of limitations with the 5mm instruments. So again, that's a problem for the industry to work on trocars and instruments that we can use in children and certainly in little children, and same for the AirSeal system. But I guess there are technological problems to reduce the size of those trocars. So there is again a question, your opinion perhaps, Hamnas, about hypothermia, about the temperature control with the AirSeal. Thomas told us a little bit about that. What is your opinion? Did you have problems with that?
To be honest, I'm not aware of it. The first time when Thomas presented, it was brought to my attention, so I need to look into it. But that's not something that any of my anesthesiologists or the team around me has brought to my attention. So I really have not paid attention to it.
Saying that your patients were had problems, temperature, hypothermia?
Not at all.
There is a much more
circulation
exchange of gas at 24 degrees Celsius, and so
right. I see the point, but I have not. That's not been brought to my attention, so I don't know.
Okay. Stephen, did you know about that? Do you have some?
We've talked about it. Again, that gets to using this in smaller patients. As we all know, when we do MIS, especially I think in neonates and infants, everybody's always concerned about the baby's temperature and cooling the baby down. So we used heated and humidified insufflation when we do those cases. I think that I think it's certainly so the patients we're using the AirSeal in, those patients are larger. We're able to keep them warmer in other ways. We use what's it called, the air warming blanket underneath them. We do a lot of things that allow us to maintain the patient's temperature. So we haven't had issues with that. But I think in a smaller child where you are circulating a lot of air, if it's not heated, it certainly could be a problem. And again, it's something I think that that CONMED's aware of, and all these things are being looked at. But in truth, most of the procedures, I think it depends on the length of the procedure as well that you're doing. And those are issues. But I think these are all important issues that need to be looked at. And again, just my caution about, going under, let's say, 10 kilos, with the use of this technology, because I think they can get there. I'm very optimistic that they will, but I think, everything needs to be downsized, and all of these things need to be looked at. Because there are very promising results in larger patients. But I think it's just something that is certainly might be an issue. Okay, thank you so much.
Henri, if you don't mind, I can just comment on that chat. You talked about the trocar, and somebody's asking whether that's an issue in pediatric patients. I agree, again, the AirSeal trocar is just about a millimeter more than what normal we use in robotics. But to be honest, robotics itself has been a big issue in pediatrics because we've had to laterally think. It's a system that's been made for adults, and we've adapted in children. So those issues in terms of trocar size has always been there, and we've had to think laterally and adapt. So I don't think another millimeter of diameter has created huge issues, although it is an inconvenience, I accept.
Yes, I can understand, but it's just because we are in a professional webinar, it's just the idea here is to say, okay, guys, you have a good material, but think a little bit to our little patients and do something for that. And you know that the industry is always lacking in this part of their business.
We've been fighting for it for a very long time. But one day, hopefully, as Steve says, technology will get better, optimistic that it will make it more safe. And we all need to express caution. And I fully accept what Steve's saying and can't reinforce it any better. Thank you.
I think if you're using a robot, the trocar size isn't much different. If you're not using a robot, the trocar size is significantly different. You guys have committed to using bigger trocars than we use, you know, so it sort of depends on your philosophy for that. But it certainly comes into a consideration when I decide whether to use the AirSeal or not, whether or not, you know, either whether it's through an umbilical port or is it somewhere that I'm willing to put in a bigger trocar, because my ports outside the umbilicus are almost always 3 and occasionally a 5 millimeter reusable cannula, which has a true diameter very close to 5. So I'm not, you know, I am conscious of that. Now, it may just purely be a cosmetic thing. There's probably some pain associated with it, but it just depends on kind of what platform you're using.
So another question is about the cost, because the cost is not nothing in this with this type of tools. Thomas told us that they limited the use of the AirSeal for complex surgeries, not for all surgeries. What is your opinion about that, or what is your what do? You use it now for every case, not children, but let us say over 10 kilo. You use it for every case, or you are also selective?
I use the AirSeal for every case now. I think the added benefits about, it's not just about the weight of the child. I think it's not about complexity. I think for every case, if you do not have leak and you don't have distractions, it helps. Because especially when you're doing simple cases, when you're training somebody, I think that's a significant advantage to relax a bit, not worry about troubleshooting issues about leak and everything else. I use it for all the cases. I suppose it depends upon the healthcare systems and how things are paid for. Our management here has not created such a big deal about it, and we are just carrying on using it. Since AirSeal was introduced, since June 2020, I've been using it regularly for all my minimally invasive cases. But I do predominantly robotics, so for all those cases, I've been using it, yes. And
Stephen, you too?
No, we're very selective because I do think the cost right now is an issue. Again, I think hopefully it will come down, but you know, procedures where air leak, or we're using different size instrumentation, or we're using it thoracically, where we're, you know, want to collapse a lung without having single lung ventilation and want to maintain that and still have some ventilation in that lung. I think it's very helpful. I think, you know, to use it on an appendectomy or a routine Nissen or a routine gallbladder, you know, generally doesn't make a lot of sense because those are procedures that take less than an hour. We don't have problems. We use the same size instruments. You know, we don't have problems with air leak. And so, you know, and even in the US, we're very conscious now about cost per case. You know, I have an adult robotic surgeon in my hospital who does all his appendectomies with a robot. I think it's crazy. I don't know how it happens, and I believe they use AirSeal in that. So, you know, I understand that, but that makes no sense to me. You know, we certainly have to be more cost conscious and in what we're doing, so I think where places where it really adds a benefit, it's very easy to justify the cost. I actually think at some point, especially in neonates, if we can downsize everything, it will definitely, you know, assuming all these issues are worked out, it may well be a huge benefit there, but in routine cases, we're not using it.
Okay. We do the same. We use it also for selected cases. One of the cases where we find it very interesting is when we do splenectomies, because when you do the splenectomy and the time you extract the spleen, it's impressive to see that with the AirSeal, even if you have such an incision on the umbilicus and to take the spleen out, you have a steady pressure inside, and you see it like you do a laparoscopic without any leak. So in splenectomy, it's very interesting, for example.
Yeah, I agree. If I have a patient who has like ileocolic Crohn's, or where we're doing a larger patient where we're doing a bowel resection, absolutely, because it allows you to do so many different things.
Yeah, the suture, the anastomosis, it's much easier.
Yeah, it's a real benefit, because we used to struggle a lot with, the point about losing a pneumoperitoneum. And so I think if you're using a lot of different size instruments, as I'll show in the spine case, if you're doing something, we put in a lot of gastric pacers for severe gastric stimulators for severe gastroparesis, where guide wire, where the leads are attached to the stomach and have to come out. And the AirSeal allows me to not worry about the air leak and all of that. Any larger resections, a liver resection, anything like that, absolutely makes a huge difference. But just, again, routine, fundoplications, gallbladders, appendectomies, things like of that nature, we just don't, just again, because the air loss of pneumoperitoneum isn't really an issue.
Okay, great. Thank you so much. Perhaps it's time now to go to your topic, Steve, and to listen to the use of the AirSeal in tethering, vertebral body tethering.
So
not always.
I taped this presentation, and I'm going to let them play that, because my hope is that the videos will run a bit better, and I'm happy to answer any questions after. But this is a very specialized procedure that I started doing 2 years ago with my orthopedic surgeon for patients who have idiopathic scoliosis, and it's extremely clever. And I've had a long history of working with orthopedic surgeons to get them access to the spine, usually for an anterior release and then a posterior fusion. Initially, we were doing those open, then we were doing it thoracoscopically when we would go in and take out the disc and then put in bone graft, and they would do it. Some people were trying to instrument anteriorly, but this is a very, very clever approach to this. And it certainly is one of the areas, it made me think about ways to use the AirSeal more in the chest, and I'll talk about it. So if you want to go ahead and play the presentation, that would be great.
Afternoon, everybody. It's a great pleasure to be with you during this seminar, and I appreciate the organizers for inviting me to speak. I am going to discuss with you a new technique that we've been doing for the last 2 years called thoracoscopic vertebral body tethering, and this is done for idiopathic scoliosis. And it's an area and a technique that we found that there's been great application for the AirSeal system in doing this. And I'll explain to you why it's particularly advantageous in these cases. But basically, we're treating children and young teenagers who have significant scoliosis using a more dynamic technique than the standard fusions that had been done previously. And we've been able to do this using a minimally invasive method and a totally thoracoscopic approach. As pediatric general surgeons, my entire career, I've often assisted orthopedic surgeons, orthopedic spine surgeons, in doing spinal repairs for scoliosis, but usually that involved getting exposure so they could do anterior discectomies and put in bone graft, and then doing a posterior fusion associated with it. And there's significant disadvantages to doing a posterior fusion in children because it fixates and makes their spine rigid. And so the very interesting and advantageous part about this is the spine retains its flexibility, which I think has great benefits for the children as they grow. The previous exposures we did, initially I was doing them open, and then we were doing it thoracoscopically assisted. And that was a technique we used probably for close to 10 years. And then a lot of surgeons got away from that. Some surgeons were actually doing anterior instrumentation. putting in screws and rods anteriorly thoracoscopically, but that was actually quite difficult. But this technique is very amenable to a thoracoscopic approach, and the AirSeal system really helps us in doing this. So again, as I talked about, the standard technique in those children who have significant scoliosis, and again, I'm not an orthopedic surgeon, so I'm not the one who determines who and when these children need to have surgery. I simply aid from the technical aspects of the surgery. But as my orthopedic surgeon, Dr. Jaron Riley, who I work with on these procedures, he's really the main surgeon. I'm sort of the cameraman and technician. But the three hurdles are that one, you need to wait for skeletal maturity or almost maturity when you do these procedures, or at least they like to. Once you've done that, there's decreased spinal motion because of the posterior rods and the discectomies. And then you can get adjacent segment degeneration. And these are all things that the spine surgeons have to deal with. And there's a principle in orthopedic spine surgery about guided growth of the spine. And the idea was that, if you started to have a significant curve, that perhaps by doing something to regulate how it grows, that you could get the spine to stretch out. And Newton in 2008 was one of the first to discuss this and thought about it. And he created a bovine model where they placed a lateral tether and watched after 6 months of growth, and they found that the spine tended to straighten because of these tethers. And the first initial attempts with this were to use vertebral stapling, but the problem was it was a rigid implant across a mobile space, and so the outcomes weren't very good. Then later on, Lenke talked about putting a polypropylene rope across these mobile segments. So, the concept of a tether as we're discussing in this procedure. And you can see a little cartoon of it right here, where you can see the tether holds it. And the idea is that, the rope, as the patient grows, as they increase their length, the rope tethers them on that side and forces the spine to straighten out. An actually very clever idea. And Newton later showed that if you did this, that the discs then maintain their hydration, the vertebral bodies turn to more of a normal shape, and the key is really maintaining that correction. And so this is where a lot of the early research on this went. The indications for doing this is it's key that the patient must have enough growth left to allow for correction of the curve. If they have too much growth left, then you can overcorrect, and you might in fact cause a curve the other way. And that the curve should have be large enough to predictably say that they will require surgical intervention in the future, and curves that are too big will not be well corrected. The tethers may break. And the mechanics of trying to overcome the curve are too great. So again, not my area of expertise, but these patients are picked by the orthopedic surgeon based on these things. And in fact, we just did our youngest and smallest patient. We just did an 8-year-old who had a significant curve, and she was only about 22 kilos when we did her. And she's by far the youngest and earliest patient we've done. So some of the indications is that the patient must be able to tolerate single lung ventilation. So just as in thoracoscopic surgery, we need to get the lung that we do for mediastinal masses and things like that. We need to be able to get the lung out of the way. And most of these patients are large enough to tolerate double lumen endotracheal tubes. But, a number of them who have severe scoliosis also have some degree of restrictive lung disease and other issues. And what we found, so the initial cases we did were not with the AirSeal. And I think it was the second or third case we did that we did have single lung ventilation, and we do that either with a double lumen endotracheal tube or we do it with a main stem intubation of the contralateral side. And we use CO2 insufflation as well to help keep the lung collapsed. But surprisingly, the child just did not tolerate it. And this was a child that did not have any known lung dysfunction, did not really have any risk factors, but she just didn't tolerate the single lung ventilation very well at all. And in fact, it hindered the surgery. And after that case, I started thinking that, you know, perhaps the AirSeal was might improve it, because even the AirSeal keeps the lung collapsed, but you still get some ventilation and oxygen exchange on that side. So we always screen for risk factors pre-op, and they get preoperative nebulizer treatments. Patients get ketamine, and they have to have a flexible curve. So there needs to be enough flexibility in the curve that the tether can overcome it. And if they have significant rotation, so sort of the spine is twisted, that can be difficult as well to correct. And most of these cases are thoracic, but we also have done thoracolumbar, and I can get down certainly to L1 and sometimes to L2 to put in these screws through the chest just by mobilizing the diaphragm medially. If we have to go lower than L2, then we usually do a concomitant sort of retroperitoneal exposure with an incision up over the iliac crest, and I make a tunnel that we pass the tether through. And we've now done a few cases as well that have a double curve where we actually do thoracoscopic procedure on both sides. And again, the ability to do this minimally invasively really is a benefit. So what is it about the AirSeal system that helps us? One is that, so these are valveless trocars. And by the way that it works with the circular air movement, it maintains the pressure without the need to have a valve in the trocar. And that's critically important in these cases, because one of the things about these spine cases is we use instruments anywhere from a 3mm to a 15mm instrument. Now, all the orthopedic instruments that they use right now to put in the screws and manipulate the spine and all those other pieces are 15mm instruments. The instruments, depending on the size of the child that I use, we use a 5mm scope, 5mm 30-degree scope. And I also use a 3 or a 5mm vessel sealer to take the intercostal vessels, and we'll talk about that more. And so we have a wide range of instrument sizes, and I'm trying to minimize the incisions that we make as much as possible. So the orthopedic surgeon needs a certain angle and degree to get at the vertebral body on each side. And if we put the trocars correctly, he usually can get at up to 3 vertebral levels from each incision I make, but that has to be a 15mm trocar. But I'm trying to limit the number of trocars we open as well as limit the number of incisions I make. And so I'll often exchange the 15mm trocar with the 12mm AirSeal trocar and 5mm trocars. And I'll talk to you a little bit more about that. So the ability to and I'll put 5mm instruments in a 15mm trocar because that's the angle that gives me the best chance to do what I need to do, or put the scope in. And so the fact that we're not having an air leak and we maintain complete lung collapse is really advantageous, and it's made a big difference in these procedures. And so I found that whether doing thoracoscopic procedures or laparoscopic procedures, in those cases where you're using larger instrumentation and smaller instrumentation, that having this system that allows for an air leak, or if you're pulling something out of the body cavity, another case we use these a lot for, we put in gastric stimulators, and we put wires into the stomach to hook up to the stimulators, which are then in a subcutaneous pocket. And by using the AirSeal system, I used to have a lot of problem putting the wires in and out with the valves and losing insufflation. And using the AirSeal system, that eliminates that problem. Also, because of the constant CO2, it tends to evacuate the smoke and moisture, which keeps our view good as well. So again, the AirSeal system eliminates the need for single lung ventilation. It allows for complete and steady collapse of the lung to provide improved visualization and safety. It allows us to use large-sized trocars without the loss of pneumothorax when using smaller instruments. And what we found is we have improved oxygenation and ventilation in some of those patients who might have some degree of pulmonary compromise, and again allows us to avoid using complete single lung ventilation. So, you know, these patients are all done in a lateral decubitus position. We put the convexity side up, and we arrange padding to allow for curve manipulation, because once we put the tether in place, the orthopedic surgeon will actually apply pressure to the spine to straighten it out as we put tension on the tether, and I'll show you that. All these patients get neuromonitoring, so to make sure that we're not compromising the spine in any way, or any of the spinal cord or the nerves at the various levels. And this is a picture of the initial trocar placement. So what I do is I'll insufflate the chest with CO2 with a Verres needle, and then I'll go ahead and put in the AirSeal trocar. I do use the larger AirSeal trocar in these cases. I tried initially to use the 5, and in larger patients, it actually doesn't circulate enough air to maintain complete lung collapse. So you want to use the larger 12 millimeter port for these. And here you can see sort of our setup. You can see that I have, you know, a 15 millimeter trocar here, the 12 millimeter AirSeal here, and a 5 millimeter port here. Here I have the scope in it, and the orthopedic surgeon is working through the port right here. And again, you can see we have different size instrumentation in ports where normally we would get a leak. And what I'll do is, so initially the orthopedic surgeon will work through this 15 port, and then I will simply take out, when he needs to work up in this part, I'll take out the AirSeal port, place it down here and move the 15 port up there, thereby saving, allowing him to get the exposure he needs, and also, you know, saving the number of disposable trocars we're using. And I can do all that without any significant air loss. And I think it's a big advantage, and also saves cost. And this is, while we're doing this, so we have a thoracoscopic view. We also have fluoroscopic view, which the orthopedic surgeon helps plan if he's got the right angle to go into the vertebral body, and then puts the screws in. And it really is remarkable. I'm very fortunate to work with a very talented orthopedic surgeon, Dr. Jaron Riley, and he is amazing at how he can, in his mind, figure out the 3D orientation in order to get these screws in the right place. As you'll see, he pounds nails in and screws these things in. And there's a lot of very dangerous things around there, big blood vessels and then the spinal cord, and it's really quite amazing how well he does this. And we've gotten quite efficient at this procedure, and in fact can do, we've done up to 10 levels in just over 2 hours, so it's quite remarkable. So this is the procedure. He decides what levels we need to do. So he'll say, you know, we need to go from T5 to L1. And so the first thing I do is I just split open the pleura over the vertebral bodies in the disc. And what I'm doing, I need to expose each vertebral body that he wants to put a screw in, and the segmental vessels are lying right over the vertebral body. So first I release the pleura over the entire length that we're going to do. And using a hook is easy to do this. You can also a sealing device that cuts. We have a new 5 millimeter sealer that I use. And now what I'm going to do is I'm going to take the segmental vessels. So this is a little 3 millimeter vessel sealer that I use. And I just make proximal and distal seals. And then I'm going to go ahead and divide the vessel. And then I'll mobilize them, especially the upper half, to expose. He wants to get into the vertebral body very near where the rib head is. And so I clear that. Here you can see we're getting down to the lower end of the spine. Again, you can see the segmental vessels coming across that we'll take. And if I need to, I can mobilize the lower part of the diaphragm. And now he's coming in, and this is an awl he uses to make the initial hole for the screw. And then once that's in place, he'll put in this device is called an all-in-one, but you can see those staples. So they actually call this a staple, and it acts as a support for the screw that he's later going to put in. So he'll, under fluoroscopic control, he'll put this staple in place. And then he has a tap he'll screw in to measure the length of screw he needs to put in. And so depending on the size of the child and the size of the vertebral body, he'll put different size screws in. And you can see the screws that have already been placed up above here. And so we'll measure that. And again, we do this. So I clear all the vertebral bodies, and then we go one vertebral body at a time as he does this. And usually the bleeding from is not too bad. It's a little oozing. Sometimes you can get more brisk bleeding out. And if that's the case, we'll put some flow seal in there to kind of tamponade it while he puts the tap in. So this is a tap, and you can see it has markings on it. And that helps him determine how long a screw to put in, because he can measure it. So my job is to show him, give him a clear view of what he's doing, of the tap going in, and also obviously to keep any bleeding structures. And now this is the screw. So he's chosen the size screw, can be anywhere from 2 to 4 centimeters usually. And now he's screwing it in. And it's really quite ingenious, this system they developed. Our hope is that actually we can reduce the size of these to either 12 or 10 millimeters and get rid of the 15 millimeter trocars. And that would be great, because then we could just do it all through AirSeal trocars. And once all those screws are in, then we put in this tether, which looks like a piece of clothesline. And he's putting down a little screw that goes inside the screw that holds that tether in place. And the device you see coming in allows us to put pressure. And so we pull on the cord, and this is the bottom of the tether there. And once we're done, we cut the tether with the harmonic scalpel. It's quite hard to get through it, so scissors itself won't work. So that's basically the procedure, how it looks. We've now done actually 18 cases. And you can see this is a kid who had a double curve that we did. And you can see the screws coming on both sides. So the X-ray is backwards. Obviously, the heart's in the right chest. So on the left side, we did a purely thoracic, and then on the right, we did a thoracolumbar. So we did the top part thoracoscopically, and then I made that lower iliac crest incision I mentioned to get to the retroperitoneum. The average time the chest tube in is actually quite short. I usually get it out by 2 days, again, because there's no lung injury and there's very limited bleeding. So I just want to make sure there's no significant drainage. We've had no problems with neurologic deficits. We've had no infections. And perhaps the most remarkable case for me was one of the first ones we did. She was a gymnastics state champion 6 months after we did this tethering. And in fact, 2 months after we did it, she was back to full workouts. It was really remarkable. And I think, in terms of long-term results, the follow-up really is too short at this point, but they look very favorable. The concern would be one for overcorrection. And if that happened, we could always just go in and cut the tether, or if the tether breaks or other things, might have to redo it, but we've not had any of those issues yet. And this is pretty remarkable. This is a child we did, and this is after we put the tether in immediately, and you can see the spine was flexible enough that with the pressure or the pull on the tether, we were able to achieve a significant correction within just a couple days. It really was quite remarkable. And all of the results we've had so far show this kind of promising results. So I think, again, I'm not an orthopedic surgeon, I'm not a spine surgeon, but I've been involved with spine surgery most of my career in giving exposures for these more severe curves. And by far, I think this is the least invasive. And what's really amazing is you go into these kids' rooms even the day after surgery, and they just want to get the chest tube out so they can go home and walk around. It's amazing how little discomfort and pain they have. The last child we did, the little 8-year-old I mentioned, she went home on the second postoperative day. It was really amazing how quickly they recover. So, in terms of this procedure itself, we hope that we may redefine indications for the treatment of idiopathic scoliosis. And, they're trying to figure out how much correction to shoot for, what's the best timing, those sort of things. I think we can improve on the instrumentation. As I mentioned, I think the idea is to try to downsize the instrumentation, make smaller implants, and a more reliable tether. But I've really been impressed, and it's actually quite fun to be involved with these cases. And as I said, I'm very fortunate. The surgeon I work with is actually very efficient and quick. And we're doing these generally in half the time that other centers are, with fewer incisions. The most incisions we've ever made is 4, and that was to do 10 levels. But often we can get by with 3. And again, I minimize trocar size where we can, which is, again, a nice part of having the AirSeal system. I think there are other thoracic indications for AirSeal. I do think the patients need to be somewhat larger, although you can use the smaller 5mm port. But if you have a large mass that you need to get out, you need a bigger incision anyway. And you don't want to risk single lung ventilation, or I think this is a nice way to do it, and we've got an excellent collapse. And I think you can also use it in lung resections, because you do get good collapse and should be able to see the structures well. And I just did a lung resection in a 16-year-old where we used AirSeal. One of the problems is if you're using the bigger ports, then you have less mobility in terms of arc for your instruments, because the rib spaces tend to not be that big. So in smaller kids, it's a bit of a problem. And even if I'm using like a 12mm stapler, I try to hold off putting the bigger trocar in until I need that. But again, I think there are certainly indications for it. The other thing, as I mentioned, is, we use it in laparoscopic surgery as well on specific cases where we're either going to need to remove a large specimen, so we're making a bigger incision, or I plan on using a lot of different size instruments, and I think that's appropriate. Or in the case of gastric stimulators, where we have guide wires that come out and would make the valves leak and things like that. So I've been very pleased with this, and certainly our patients have not had trouble tolerating the lung collapse with the AirSeal system. I think it gives a constant pressure, and the anesthesiologists seem very happy with that. And I think we've had great results. So that's pretty much it. I'd be happy to take any questions you might have. And again, thank you for the opportunity to speak with you all today.
Okay, thank you, Steve. I think probably we are at the end of the webinar, because the Zoom platform will close very soon. So are there some still questions? Ramnath, have you something?
Not at all. I stay away from the spine as much as possible. I'm a urologist, so I wouldn't, but it was impressive. I think the idea is fabulous, and it's always the stage of your career where you are, Steve, and where I feel as well. I think it's just great to be able to facilitate and then the indications and stretching it is amazing. So yeah, that's all I have to say.
Okay. So thank you, guys. I think it was very impressive, this last topic, but the 2 others were very nice and very, I think, explained well the potential advantages of the AirSeal. So thank you, everybody, to be with us this evening or this morning or this lunchtime. I don't know, depending the area of the world you are listening from. So again, a very good new year, and hope to see you all in the IPEC Congress and then in the ASPES Congress. So May or June, I think, for the IPEC, and September for the ASPES meeting. We will speak again a lot about AirSeal, I think, during those congresses. So thank you so much, and bye-bye.
Thanks, Henri.
Thank you. Thank
Bye,
you.
everybody.
Bye, everybody. Bye.